अभी तो खैर इसमें है. Good morning. So, my name is Anita Saxena. I am from All India Institute of Medical Sciences. I think we've had one or two couple of talks in the last 1 year. So, I welcome you all. And the talk that I've been asked to give on is non-specific. In fact, it says aortoarteritis, but I'm specifically calling it non-specific aortoarteritis or NSAA in short, simply because there could be many reasons for arteritis, which we are not going to discuss. What we're going to discuss is something called Takayasu's arteritis, which is an acquired disease. Although we see it in children, but it's an acquired disease, and therefore it falls into the category of acquired diseases like rheumatic heart disease, pericardial disease, like that. So it has several names. I'm not going to go into that, but I think commonly it is called non-specific aortoarteritis or Takayasu's arteritis. So what is Takayasu's arteritis? It's actually a chronic inflammatory disease. So it's not infective, but it's an inflammatory disease that would involve aorta, its branches, usually the big branches, and it can involve coronary arteries and pulmonary arteries rarely. But often it involves aorta and its branches right from the beginning, from the ascending aorta, arch, descending thoracic, abdominal aorta, and so on. What it causes is basically vessels get stenosed over a period of time, sometimes completely occluded, and there could be dilatations and aneurysm formation in areas. So it's like a chronic disease of almost whole of aorta, although it may have normal regions in between which are skipped. It was described for the first time long time ago. However, Takayasu, who was a professor of ophthalmology, described it for the first time in 1905, and he picked it up from the fundus abnormality where he saw lots of arteriovenous connections and malformations, and that is why it is also called Takayasu arteritis. In 1951, Shimizu and Sano from Japan described its clinical features, and the main clinical feature of aortoarteritis is pulselessness. That means one or more pulses of a patient would be absent, and that is why he named it as pulseless disease. So I think we as cardiologists are more interested in what happens to the aorta and its branches. Of course, there could be fundal abnormalities secondary to Takayasu disease or aortoarteritis. Although it has no geographic restriction and there is absolutely no specific racial disposition, but it is very, very uncommon in the Western world. We often see it in Southeast Asia, Africa, South America, rather than you will hardly ever see a case in, let's say, United States or North America for that matter, and even in Europe and UK. And so much so that it is probably the commonest cause of renovascular hypertension in Asian children. So if we have a hypertensive child, we need to think about aortoarteritis producing renal artery stenosis. Its incidence is quite low. We don't know really the prevalence in Asia, but I can only say that we do see about 4 to 5 cases every year, new cases every year at our institute. It specifically affects under 40 years of age. That's a very, very important finding, because if you have a patient who is more than 40 years of age, we have to think about atherosclerosis as the number one diagnosis. But under 40 years of age, aortoarteritis is an important diagnosis. It is commonly seen in second and third decade, but it has been well described in children under 10 years. And when we analyze our data, we found a lot of patients were under 12 or 13 years of age. It is far more common in females than in males. And although the ratio has been described as 9:1 in Japan, from India, there are various series, and most of them would say something like 2 to 6 times more common in females than in males. Also, geographically, there has been some pattern in the vascular distribution or vascular involvement. Aortic arch and its branches are more commonly involved in Japan, whereas when we look at data in India and Korea, then it is more of disease which involves thoracoabdominal aorta. There are some reports of genetic susceptibility, but I wouldn't really dwell on it because it hasn't been found to be or proven to be of any significance. And I think in our last series, we have only one family where 2 sisters are affected with the same disease. Otherwise, these are all sporadic, isolated cases. Like rheumatic heart disease, we don't know what is the exact pathogenesis. In the past, we used to think that tuberculosis is perhaps one of the ways it produces aortoarteritis by an autoimmune kind of mechanism, but then over a period of time, tuberculosis prevalence has gone down, and now we see it in about half of our patients. Rheumatoid arthritis, ulcerative colitis, other connective tissue diseases, etc., are often described with aortoarteritis, but is there a correlation or not, we don't know. I think what we can say with some amount of certainty is that whatever we see is more of an immune mechanism, and we really don't know how it happens and why it happens. It primarily involves the elastic arteries, and as I said, it results in stenosis and sometimes aneurysm and dilatation. Most of the time, the affected arteries would be subclavian arteries, bilateral, brachiocephalic, carotid, which are the branches of the arch, vertebral, and renal arteries, but can also involve aorta itself. It rarely affects coronary and pulmonary arteries, and I will show you a couple of examples of those. And what is important is that it is almost entire aortitis, that it is not just one part of aorta. In the same patient, you can have multiple regions of involvement with normal areas in between. Sometimes you can even have a diffuse involvement. Pathology, grossly, as I said, it involves mainly the elastic arteries. There will be intimal thickening. To begin with, in the acute phase, you might find even thrombi. You can find a lot of infiltrations if you see histopathologically. But when it gets into the chronic phase, which is also called the pulseless phase, then you see more of fibrous tissue, very thick intima, very thick adventitia. And obviously, in the chronic phase, you don't find much of inflammatory cells. In adults, it has been described that if it is gone on for a long time producing hypertension, then you can have secondary atheromatous changes in some of these arteries. This is the histopathological slide, and you can see that the intima is so much thicker, although you have fibrosis in all the three layers of the vessel. How do you diagnose it? That's a question that has been on people's mind for a long time. There are 2 or 3 sets of criteria that have been described. One is called Ishikawa criteria, which was described in 1988, which gives one obligatory criteria that has to be there. That means age has to be under 40 years of age. Then you have 2 major and 9 minor criteria. And if you have 1 major and 2 minor, or 2 major or 4 minor, along with an obligatory criteria, then it is said to be highly suspected of Takayasu's arthritis. Remember, there is no diagnostic lab test that will make its diagnosis. You have to have a very high index of suspicion, and of course, angiographic picture is quite typical. In 1990, we had American College of Rheumatology giving the criteria of Takayasu's arthritis, which are a little different. There are actually 6 criteria given, and of these 6, if 3 are present, then it is 3 or more are present, then it is likely to be very sensitive and specific for aortoarteritis, sensitivity being 91% and specificity 98%. And you will see that there is no obligatory criteria like age less than 40 years. Even if you have 3 other criteria and not of age, it can still be called aortoarteritis. So it's a diagnosis which is made more like clinically and of course sometimes angiographically, because both these criteria have arteriogram abnormality as one of the criteria. So in real practice, how do we diagnose? We diagnose based on clinical examination, that if you have somebody who is relatively young and has absence of pulses, has hypertension, then we need to think about aortoarteritis. Of course, the angiographic morphology is quite typical, as I told you, and I'll show you some more examples. And if you happen to pick up a patient in the acute phase, which is not very common, then there may be history of constitutional symptoms like fever, joint pains, sometimes skin rashes, lethargy, fatigue, and so on, for which obviously you don't have a cause. At that time, all the pulses may be palpable, and therefore the diagnosis may actually be missed. So what is the typical angiographic finding? Luminal irregularity, vessel occlusion or stenosis, and at times dilatation. And as I said, that you can have involvement with skipped normal areas in between. It is more of a vasculitis involving almost all of aorta and its major branches, but you can have absolutely normal areas in between. How do we classify? You must have heard about aortoarteritis type 1, type 2, type 3, type 4. So there have been several classifications that have been given. In fact, there is a classification given by one of our colleagues in India from Chandigarh, but conventionally we follow this classification, which is basically if you have involvement of only aortic arch branches, it is called aortoarteritis type 1. If you have involvement of the ascending aorta and the branches, then we call it 2A, and if you have an involvement of up to thoracic aorta, then we call it 2B. In 3, there is involvement of abdominal aorta and thoracic aorta both, and in 4, only abdominal aorta is involved, thoracic aorta is normal. Type 5 is the one which has involvement of practically whole of aorta, which is like a diffuse variety. So classification is primarily on angiographic morphology. If there is involvement of coronary arteries, we call it C+. So you write aortoarteritis type 1 C+, or type 5 C+. If there is involvement of pulmonary arteries, we call it P+. So you might read some classification where involvement of coronary arteries and pulmonary arteries have been given an additional number, like number 5 or number 6 or number 7. But this is what conventionally is used, and this is what I think we should use in clinical practice, that you say type 1, type 2, type 3, C+, or P+, in case there is an involvement of coronaries or pulmonary arteries. Obviously, all this diagnosis will be based on angiography. So what are the angiographic findings, and where all it can involve? Subclavian artery involvement, very, very common. It could be left or right or both. Then of course thoracoabdominal aorta, which as I said is more common in Asians, more common in children. What is important to understand is that there are no intercostal collaterals, and this is very unlike coarctation of aorta, where you can also have involvement, that you have an obstruction, and therefore clinical findings may look like aortoarteritis, but there are hardly any intercostals in aortoarteritis. In a long-standing case, you might see calcification in the aorta. Rarely you can have secular or fusiform aneurysm, but often associated with stenosis. So having just aneurysm may not be very typical of aortoarteritis. Also, it is important to remember that despite so much of disease in the aorta, pseudoaneurysms, dissections are extremely rare spontaneously. So rupture of aorta, dissection of aorta, these are not findings often seen in aortoarteritis. So here is an example of an angiogram where you see descending thoracic aorta diffusely involved, and you don't see any collaterals. It's like it's also called like a bare aorta. So that is pretty typical of aortoarteritis. Other imaging, yes, besides angiography, you can do ultrasound, which will show you increased wall thickness, and therefore you might start suspecting. CT angiography is very, very useful because angiography is an invasive procedure. So sometimes just to get an idea of what is going on, you can do a CT and see for the wall thickness. In some of the active cases, you can actually see wall enhancement. And when we talk of activity, I think MRI and FDG PET are two very, very important tests, specifically FDG PET, which is supposed to be very, very accurate for assessment of disease activity. Now, why I talk of activity, I will let you know when we talk of management. Because if you can pick it up during the active phase, then maybe there is some specific treatment that you can give and prevent the progression of disease to a chronic phase. Here is a CT where you can see marked concentric thickened aortic valve, which has been pointed out. This is descending thoracic aorta, and you can see the wall. See, look at the lumen and look at the wall. The wall is so much thicker, the lumen is so much smaller. This is FDG PET, which, as I said, is the most accurate way for assessment. There are lots of studies that have come up, since I think 2010 or so, where it has been used to assess activity. But FDG PET is not a simple test. It is like doing 2 CTs, so you don't want to do it again and again, and therefore we don't do it as a routine. But yes, in some cases where you're not sure, you could do FDG PET to see if there is activity or not. And of course, in the follow-up of cases, once you've treated them for active phase. What are the clinical features? You can divide them into 2 stages, early and late. It is very, very difficult to pick up patients in early phase. Many a times, actually, if when you ask these patients about history of constitutional symptoms in the past, only 50% will give you that history. So this is quite typical of what you see in rheumatic heart disease, where the patients present to us with valvular involvement, and only 50% of them will actually give you a history of rheumatic fever in the past. So in the pre-pulseless phase, pulses are palpable, but there are constitutional symptoms, arthralgias, night sweats, fever, weight loss. There could be splenomegaly, there could be lymphadenopathy, very, very non-specific. And usually the acute phase would last about 3 months, and the patient will become asymptomatic on its own without any therapy many a times. And as I said, 50% of patients may not give you any such history. However, when you pick these patients in the late ischemic phase or pulselessness phase, then you will see all the sequelae of occlusion. Therefore, some of the pulses will be absent. At least 1 or 2 pulses will be absent in as many as 90–95% of cases, and that is basically the hallmark of making a diagnosis of aortoarteritis. You may, if you make an effort, you will be able to hear a bruit in 80–94% of cases, and as many as half or even more of these patients will present with hypertension. So if you pick up hypertension in a child, think about aortoarteritis, because we know essential hypertension is most uncommon, and I think every child with hypertension deserves all the pulses to be examined to make that diagnosis. If we only examine upper limb and lower limb pulses, we might miss, because sometimes there may be involvement of carotid and you have not looked at the carotid. You can actually get a bruit over the carotid in many of these patients. Some of these patients will present with heart failure, and heart failure will be more because of left ventricular dysfunction, and we will come to it, as we go on. So the usual presenting symptom would be hypertension, heart failure, and it is the onus is on the physician or the pediatrician to examine all the pulses to make this diagnosis. Otherwise, obviously, you're going to miss it, and you're just going to think about renal hypertension, secondary hypertension, primary hypertension, and so on. So any patient presenting with these features, especially if there is heart failure without any murmur, think about aortoarteritis. And I will show you some data that many of these patients present in a picture like that of cardiomyopathy, and we tend to miss it simply because we haven't looked at all the pulses. Rarely you can have constitutional symptoms. As I said, fever, arthralgia and all that. There could be tenderness along arteries, especially in the acute or subacute phase, bruit, claudication, and of course missing pulse, which is the hallmark. We are often asked, I think the students are often given a case of coarctation or aortoarteritis and are asked in the exam, how do you differentiate the two? And I think in majority of cases you can make a differentiation. It's usually a child of 10 years, 12 years, 15 years that you are, you're given in the exam, and then there is absence of femorals. Remember that coarctation is far more common in males, whereas aortoarteritis is more common in females. And in coarctation, it's only the femoral that are going to be weak unless we're talking of aberrant subclavian. But in aortoarteritis, it could be any of the pulses. So even upper limb pulses, carotid pulses may be weak, and not necessarily just the femorals. Femorals will be weak if you have involvement of aorta, in the thoracic or the abdominal part, and in that case, it will look like coarctation of aorta. Also, very often in coarctation, you will have associated congenital heart defects. I think all of you know bicuspid aortic valve, aortic stenosis, VSA, and all that. No, there is no such thing in aortoarteritis. Claudication is common in aortoarteritis, but not seen in coarctation because you have lots of collaterals. And bruit over the back that we get sometimes in coarctation because of intercostal collateral will again be absent, because as I told you, there is a bare aorta. There are no collaterals arising out of descending thoracic aorta simply because their orifices are involved. And therefore, bruit over the back of the chest is quite typical of coarctation, whereas bruit over the abdomen is quite typical of non-specific aortoarteritis. So I think most of the cases you can make a differentiation. Also, if there is the patient is presenting with heart failure, remember heart failure is not a sign or a symptom of coarctation of aorta at that age. If heart failure has to occur in coarctation, it will occur in neonatal life or much later in life. But if somebody presents in young age, second decade or so, then heart failure would not be a feature. So heart failure again points to aortoarteritis and not coarctation of aorta. So why does hypertension occur in aortoarteritis? Commonly because of renal artery stenosis, which could be unilateral or bilateral, but sometimes hypertension in the upper limb could be because of obstruction in the thoracic or abdominal aorta, and that produces picture quite typical of that coarctation of aorta. So you have to have a differentiation, and I told you the points. Remember, it is the commonest cause of renovascular hypertension in Asian children, so you have to keep that in mind. And sometimes when there is renal artery involvement, you may not have other involvement, therefore you are likely to miss clinically because other pulses are present. So you have to keep a very high index of suspicion for renal artery stenosis in any child presenting with hypertension. But hypertension may actually be missed simply because of subclavian artery narrowing. Therefore, you take blood pressure in the upper limb and you don't pick it up because the subclavian is involved, and therefore the pressures are not high. Sometimes severe left ventricular dysfunction, almost like cardiomyopathy picture, may suppress blood pressure, and therefore you may not pick up hypertension in those cases. But I think if you have hypertension along with absence of pulses, renal bruit or aortic bruit is almost diagnostic of non-specific aortoarteritis, and there is really no other diagnosis, at least in children under 20-30 years of age. This is an example of bilateral renal artery stenosis, and you can see that there is involvement of the perirenal segment as well. So there is aortic as well as renal artery involvement. Look at this, quite narrowed, and even this one is quite narrow. Most of the time it is the ostia of the renal arteries that are commonly involved, but as I said, they could be perirenal narrowing, and that's important because when we are taking them up for intervention, this really interferes with our intervention, with our approach, because to hook the renal arteries and to dilate them in the presence of such a thin aorta is quite challenging. The other thing that we need to remember is that If there is unilateral artery stenosis, renal artery, then also your use of ACE inhibitor should be very carefully considered, and of course they are contraindicated in bilateral renal artery stenosis. So when we are treating hypertension, we have to make sure that we are not giving them ACE inhibitors. Now coming to heart failure, what are the causes of heart failure in aortoarteritis? The most common cause would be hypertension, and as I said, sometimes these patients are so much in heart failure that you may not get much hypertension. You may get a pressure of something like 130/85 or 140/85, and you wonder that this amount of hypertension will not lead to heart failure. But remember, it has been severe hypertension for a long period of time which has actually produced LV dysfunction, and therefore the patients are not able to show that they are hypertensive. The other cause of heart failure could be myocarditis. So as I said, active disease. It involves aorta and its branches, but there is a lot of data to say that it could be myocarditis as a part and parcel of the active disease, producing a picture like that of cardiomyopathy. Rarely, coronary artery involvement can give you heart failure because of myocardial infarction like picture. Sometimes you get involvement with the aortic valve, producing severe aortic regurgitation because of dilated ascending aorta, and that can give you heart failure. And rarely pulmonary artery involvement, producing pulmonary arterial hypertension of the central pulmonary arteries and producing heart failure. It is important to understand that heart failure is an important cause of mortality and really gives you a prognostic value, because heart failure means very severe disease. And as I said, that many a times it is misdiagnosed as dilated cardiomyopathy. In fact, we have presented this paper at the American College of Cardiology meeting, wherein we found 19 children who were diagnosed to have severe LV dysfunction were actually having non-specific aortoarteritis. And obviously, if you diagnose them as non-specific aortoarteritis and not cardiomyopathy, you can take them for intervention, and majority of these patients were actually underwent intervention and were found to, their left ventricular function was found to become better with time. So it's one of the causes of so-called treatable cardiomyopathy and has to be kept in mind in a young patient. And therefore, if you label somebody as cardiomyopathy at 10 years, 12 years of age, you have to exclude aortoarteritis, because if you can diagnose that, then you're dealing with a treatable condition, and obviously the prognosis improves markedly rather than calling them cardiomyopathy. And I think the other important lesson that we learned was that majority of these patients were actually not hypertensive at presentation. In fact, some of them present with like a flash pulmonary edema, and the pulses were weak. So once you treat them with with dobutamine, dopamine infusions and make them a little better, then you realize that they have unequal pulses, one of the or two of the pulses may be absent, and also that their blood pressure, which was like 100/70 or 110/70, became 130, 140 with treatment, suggesting that there is hypertension. I think one clue that you can get on echocardiography is the presence of left ventricular hypertrophy, which is really not a hallmark of cardiomyopathy. So if you have a cardiomyopathy patient who has a little bit of left ventricular hypertrophy, you need to think about aortoarteritis. And I'll show you one example. This is one of our patients who had, you can see, very dilated left ventricle with poor contractions, and we thought that this patient might be having aortoarteritis. We tried to look. There is no coarctation, as you can see in the suprasternal notch, but what we found that as you put a probe in the abdomen or in the subcostal window, then you find obstruction in the descending thoracic aorta at the region of thoraco-abdominal connection, and you got this kind of a high velocity jet. So you have to keep a very high index of suspicion in any patient of cardiomyopathy before you say that this is idiopathic cardiomyopathy or the hypertension is because of something else. So I think aortoarteritis will be diagnosed more and more if we think about it more. Here is an example of left main coronary artery. It may be stenosed, it may be occluded, and I think it's important to remember this because these patients may present with myocardial infarction, angina, or heart failure simply because of coronary artery involvement, which has not been suspected. It is not uncommon that many of these patients actually present to neurology services, and then we are called to see the patient because patient has hypertension, and they present to neurology because of involvement of the carotid arteries, vertebral arteries, or because of severe hypertension. So they present with headache, visual disturbances, even syncope, transient ischemic attacks, and sometimes a full-blown cerebrovascular accident. So if they are found to be, if they are young, if they are found to be hypertensive, I think they need to be investigated for aortoarteritis. Now coming to the management, since we don't know the etiology, since we don't know what causes it, we are kind of in the dark when we are managing these patients, and therefore the management is not really very, very scientific. But what people have done in the past is that if we catch them in acute phase, then we can treat them as any other form of vasculitis, which is like immune based. And since we are thinking of immune disease, we obviously come to steroids. And steroids have been used 1 milligram per kilogram per day dose, sometimes over 2 months, 3 months, and it has been found that the acute disease may become better in as many as 60%, and this is called remission. Now again, to say that there is remission or it is a spontaneous remission is very tough, but steroids are commonly used. In cases where you find that steroids are not helping, patient continues to be active, then we can use other immunosuppressants, simply what you use in cardiomyopathies or myocarditis, and these are cyclophosphamide, azathioprine, methotrexate, and so on. It is important to understand that when we are using these drugs, we must rule out infections, because if there is underlying tuberculosis and if you are using these drugs, then obviously you might make the patient worse, and therefore treatment has to be really balanced, and one must rule out infective etiology associated with NSAA, which is associated in many cases, as I told you earlier, before starting these drugs, which can be really harmful. There are no large studies that are available, and as I said, many of these patients are never picked up in the acute phase, therefore we obviously don't give them steroids. But if you do pick up, if you make a diagnosis, and if you think patient is active, and I'll show you how do you determine activity. These are the clinical determinants of activity. If you have constitutional symptoms, fever, arthralgia, musculoskeletal pain without any other cause, elevated ESR, and then sometimes absent pulses, sometimes tenderness over the pulses, asymmetrical blood pressure, there may be some kind of joint swelling also, then think about activity. Now, angiographically, to say that the patient is active or not is not easy, because what you get may be just irregularity, some thickening of the wall. But I think MRI and now FDG PET are very, very useful to decide whether there's activity or not. So in doubtful cases, you can take these patients for FDG PET if it is available. However, in majority of cases, especially children, you have to think about active disease, because this is the time that they tend to have acute vascularity. If you have a 20, 30-year-old patient, then he or she may not be active. But I think children often tend to be active, so we have to actively seek for all the features which might suggest activity, and if necessary, do test other imaging techniques. Now, in chronic phase, where majority of our patients present, I think what as cardiologists can offer them is balloon angioplasty of the stenosed or the occluded segment, whether it is aorta or it is renal arteries or it is carotid arteries or the subclavian arteries. Subclavian arteries, we tend to dilate more often if there is claudication, but renal arteries and aorta are almost always dilated because they are likely to produce symptoms of hypertension or failure. No, angioplasty is best done in the chronic phase of the disease, but I think we have done a large number of angioplasties in the acute phase also, because many of these patients are so sick. Either they have severe LV dysfunction, they are in failure, some of them presenting in flash pulmonary edema, or they have severe hypertension. Then it is not a good idea to give them steroids and wait, because steroids or the activity may last for 3 months, and it is better to do an angioplasty even in the acute phase in such cases, although you would avoid it in a stable patient. When we do angioplasty in active cases, we have to be extra careful because complications are more likely to happen, and therefore we tend to underdilate them. Maybe we use a smaller balloon than we would have used in a chronic phase, and then we let them recover, because some amount of dilatation would be good enough for them to recover from that acute stage of left ventricular dysfunction or hypertension, and then over a period of 6 weeks or 3 months, we can actually take them back and redilate them. And this is not uncommon, because this is a disease which keeps on going into remissions and relapses, and therefore sometimes you have to do several settings of angioplasty in these patients. Now this is about renal artery dilatation. Renal artery dilatation, if you find renal artery stenosis, it's going to be a very useful modality, and you will get success in as many as 90% of the patients in the immediate period. Many a times you have bilateral renal artery stenosis, and as I said, if you have severe obstruction in the aorta also at that time, that will be quite tough to dilate. But like this patient does not have much, and therefore dilating renal artery is not going to be so difficult, and you put a balloon and you look for a waste. Blood pressure is likely to be controlled in more than 60% of children, and restenosis may occur in 20 to 25%. So you have to keep them in follow-up. We don't encourage stents in small children because we know that stents are not likely to grow and they may show instant restenosis. So often we dilate them, unless of course there is a complication or the patient is coming back again and again with hypertension. Then you may have to put a stent in the second sitting. The other area where you will dilate would be aorta. and that obviously in cases where there is involvement of thoracic or abdominal aorta, it's again a very successful procedure. You can get a success rate in 90% or so, but there is a restenosis rate of about 14 to 20% on follow-up. Therefore, all these patients need to be followed up. And as I said, if you have a 5 or 6-year-old, it's better to avoid stent. But if you have a 10 or 12-year-old, you can put in a stent in patients of aortoarteritis. When we dilate, the complications are not uncommon. You can get flaps. In fact, you always get a little bit of dissection. If it is localized, producing a small flap, you can just leave it. It's likely to remodel over a period of time, sometimes remodels with an aneurysm. But if it is a large dissection, then we have to be ready with stenting, especially covered stent. Rarely rupture of aorta has been described, and therefore my plea to all the interventional cardiologists is that if you are dilating, please underdilate. This aorta is inflamed, this aorta is disease beyond what you see on angiography. Histologically, it is disease much more, and therefore use a smaller balloon. You can take them back for another setting 6 weeks, 8 weeks, 3 months later, but at least you will not give them a complication if you dilate with a big size balloon. Surgery used to be performed earlier, but I think now with interventional cardiology, it's hardly ever performed because the disease tends to be diffuse and it tends to be progressive. So you usually will use it, reserve it only for cases which are failure after balloon dilatation, or if there are large aneurysms. And of course, now we have covered stent, so we can use that. But in children, sometimes covered stent is a big problem, so you may have to go for surgery in these cases. Now here is an example of a young girl, I think about 13-year-old, which we found in the which we received in casualty with pulmonary edema, severe congestive heart failure, pressures normal. I mean, I wouldn't say normal, but they're not hypertensive. She was more like 120/80, and pulses at least at that time appeared to be fine. But as she recovered, her lower limb pulses became worse. Her upper limb pulses started showing hypertension, and although we thought that she was likely to be active because she had a very short history, but we had no choice but to take her to the lab and do a digital subtraction angiography. We often do DSA rather than an angiography because DSA can be done with much smaller volume of contrast. And many of these patients who are having left ventricular dysfunction, you are very, very sensitive to the volume of contrast. Therefore, you do a DSA and you can see such a diffuse disease happening in thoraco-abdominal aorta, almost at the junction. In this patient, obviously, you can see underwent a balloon dilatation with quite a small balloon. But then we didn't want to really exceed the size because we thought if we give a big balloon, then there might be dissection, there might be rupture, being an acute case. So we dilated with a small balloon, and she recovered significantly. And here is her X-ray. You can see that this was the X-ray she presented to us in the casualty with pulmonary edema, and not long after that, after the dilation, I think within about a week or so, this is the X-ray. You can see so much of regression of cardiomegaly. Her pulmonary edema has gone, and left ventricular function also showed some degree of improvement while she was with us. So there was significant improvement simply by dilatation, and we all know that she's going to come back. We all know that we'll have to dilate her again. And but I think in the acute phase, it is better to stay safe. This is another example in a 12-year-old where actually you ended up giving a stent because patient had dissection, so we gave a stent to make the things better. So stent sometimes has to be used, and I think you usually require very long stents. You have to make sure that the branches are not occluded. Unfortunately, this patient did not have renal artery involvement, and therefore stent could stop over here above the renal artery and start very early. So because the diseases tend to be long and diffuse, so majority of these patients will really require long stents. Complications, yes, can occur. You have to be careful. This is the one child I have taken from one of the reports in Indian Heart Journal 2014, that a stent has been placed, and then you can see that soon after that you see a rupture. This patient was successfully managed with a covered stent, but then you have to be ready with this, and you should try and keep covered stent in stock if possible. But most of the time, what we do is underdilate them, bring them back, dilate again, and do kind of a stage dilatation, because to us that seems better rather than putting a stent, especially if it's a small child, because once you put a stent, you've kind of committed to him to that size. What is the prognosis? Mortality is 10% to 30%. There are 3 blast series in children. Unfortunately, we don't have a lot of data. But yes, angioplasty has definitely improved the long-term outlook in these patients. But patients who present with severe hypertension, LV dysfunction, retinopathy, class 4 symptoms with a lot of cardiac involvement do not tend to do well. especially presenting if they are presenting in heart failure, and their prognosis may not be very good. Even if patient has improved, this disease is such which can keep on going into remissions and relapses. It is good to follow them up even if they appear stable. So you follow them up clinically, you follow them up by imaging if necessary, and rarely you may have to bring them back for angiography. Repeat intervention is not uncommon in these patients, so you need to keep that in mind, and this patient has to be counseled accordingly. These are the three large series I was telling you about in children. Overall mortalities come as 10 to 31% in these three series, but it tends to be higher in children compared to in adults because many of them have an acute phase, many of them have marked involvement, and therefore they tend to do worse than their adults. So finally, my conclusions will be that non-specific aortoarteritis is a chronic inflammatory disease involving aorta and its major branches. It is more common in females, almost 6:1 in India. Hypertension in the presence of missing one or more pulses is almost diagnostic, but many patients will present with severe LV dysfunction like that of cardiomyopathy with normal or a very little rise of blood pressure. So one has to keep a very high index of suspicion for these patients. Interventional procedures which can be offered to majority of them have considerably improved the prognosis and long-term outlook. However, since we do not know the basic etiology, so I think it remains quite a challenge because the disease can present in so many ways, so many forms, so many arteries involved that it really remains quite a challenge for all of us. Thank you, and I'm happy to take questions. Okay. So there is one question: is there any specific cutoff values of disease activity markers before sending the patient for surgery? First of all, I wouldn't send a patient for surgery. That's my first answer. As I said, surgery is hardly ever done for this disease. We often do intervention. There are no cutoff values. We would want ESR to be normal. We would want patient not having constitutional symptoms or fever. That is what we generally clinically take it as activity. And if intervention is required, you would rather wait for the activity to subside rather than doing it during activity. But I think we are often pushed because the patient is very sick. So you would take up an intervention even during activity, as I said, but under dilate or be a little careful and maybe follow it with steroid therapy. So there is no cutoff as such. An intervention is not a contraindication during activity, but it is a relative contraindication, and therefore you should keep it for only desperate cases.